Hi, I'm Dr. Allison Cole, sleep medicine specialist and bona fide chronic insomniac. Welcome to the Sleep is My Waking Passion podcast. Remember, knowledge is empowerment, and if applied correctly, it can help you biohack your way to a better night of sleep, just like I did. Hello, everyone. You know who I am. I'm your host, Dr. Allison Cole, and I am joined today by Dr. Parul Yadav. We are going to be discussing menopause and sleep today. Welcome to the Sleep is My Waking Passion podcast. Welcome, Parul. It's so nice for you to be here. So, Dr. Yadav is a former OBGYN. I actually met her because of what I do during the day. I see patients, but I also work for continuing medical education. And women's health has been a hot topic that we've been wanting to talk about, and I really needed her expertise. And in having our chat, I was like, oh my goodness, you'd be perfect. Please, please, please come share with me your expertise in the podcast, share it with the world. And she said yes. So I'm really excited. So some background information about her. She has transitioned a successful career from being a clinician, an OBGYN, taking call just like me, having a crazy life, to being a medical writer. And she's a fantastic medical writer. You actually did 2 trainings. So you trained initially in India as an OBGYN. And then she came here and she did her residency in OBGYN at Bay State, which I did an ICU rotation there. It's a fantastic hospital. She was at UMass School of Medicine, which is affiliated with Tufts University, which is my alma mater. So we got some Boston training all up in here. Yeah. So she has international, she has U.S. clinical experience. She has a very broad and deep understanding of clinical medicine. And I can assure you, having read her work, she really does. I'm not just making this up. So she now has a company. It's called InPrint Medical Communications, and she actually works with various folks in the healthcare industry. So she does things like works for pharmaceutical companies. She works for continuing medical educational companies, like she did the work for us, other medical organizations. And so she has a real passion for education. She's educating both healthcare providers, as well as providing patient resources. So welcome, Parul. Thank you. That was a long introduction, but well worth it. You deserve it. You deserve that accolade.
Oh, thank you, Allison. It's a pleasure to be here. Thank you for having me. And yeah, thanks for that introduction.
Today, we are going to be talking about women and our sleep very specifically. But I'm good. I know that naturally our hormone milieu, there's a lot of stuff that's changing with what we understand about women and sleep and how hormones impact it, and more literature coming out. And I know that sleep even can start to become an issue just when we hit puberty. Like oftentimes our sleep patterns are very similar, girls and boys. We hit puberty, that starts to change. And guess what? It continues to be different and unique for women. So we're going to be focusing more on women in the later stages of life. But let's first start off with just how common are sleep problems in women. Can you tell everyone that?
Yeah, sure. So, where do I start, right? Menopause. So I was just going through some data the other day, and if you look at the data, it's astounding. Can you believe, Allison, that there are right now 47 million women entering menopause every year in the U.S.?
47 million.
47, isn't it?
There's a lot of us. This is important.
Yes, and of those 47 million, only 50% know about menopause. So, of those 47 million, again, about 60. So literature says 40 to 60. Lately, data has been showing that 69% of the women have sleep problems. So 69% of that 47 million is actually spending sleepless nights. And it's not just that, they can't sleep. It's going to sleep, initiating sleep, waking up multiple times at night, waking up at night with night sweats. These are issues that have troubled women in that age group, and they continue because women don't seek help. So yeah, it is a problem that we see very often in that age group. And it starts right around perimenopause, or even before, years before, as you said.
So perimenopause. What define, like, how do people kind of know? My understanding is that it's more of a symptomatology based type of approach. And so what kind of defines perimenopause? How do you know you're in menopause versus perimenopause? What do you want women to know about this time in their life as they get older?
Sure. So women generally, on an average, they go through menopause around 45 to 55. The most common age is 45, but it's a tricky situation, right? It's not like you can do a drug test and you can say, okay, you are in menopause. As you said, it is the symptoms. What does the patient come with? Is she complaining of irregular periods? Initially, in perimenopause, the periods become irregular. Okay, what happened? I just had a period last week. Now I'm bleeding again. It's irregular, heavy bleeding initially, and as your hormone levels decline, the period becomes more spaced out. And eventually there comes a time when you have a period, and then for an entire year after that, you don't have a period. So that is what menopause is. When you do not have a period for a whole entire year without any other pathological reason.
What are some of the symptoms of perimenopause that sort of maybe let you know that you're sort of headed in that direction?
Sure. So
besides the irregular periods, especially for us ladies who may not have a uterus anymore, for example.
Yes, that's a good question. If they have an IUD or you don't have a uterus, there are other symptoms that you can tell that you are going through perimenopause, and they would be sleep disturbances. There are a lot of psychological effects that women feel. There's mood instability, so you will feel irritable all of a sudden. Then there is weight gain. There are metabolic changes that are happening, so you will experience more adiposity, fat that we see around our bellies. Like as soon as you kind of hit 44, you're like, okay, why can I not lose weight? I am gaining weight around my belly. Or then symptoms like, you are not able to fall asleep. So these would be the common symptoms that you would see.
And do vasomotor symptoms start around that time as well? What we like hot flashes and such?
Yeah, so the earliest signs and symptoms, as I said, you would see would be irregular periods, the mood changes, the irritability that you see, memory gaps, brain fog, and further down you go, you see those changes too.
All right. So initially it seems to be more vague stuff that you see with your mood and these types of things. And then the hot flashes tend to come a bit later.
Yeah.
Okay.
So for that, you have to kind of understand the physiology of hot flashes, right? It's like, so as you go through perimenopause and menopause, your hormone levels, that is the estrogen and progesterone, they're decreasing. So these hormones, they work in your brain. There's the hypothalamus. That's where these hormones work. So they, in our thermoregulatory center, what they do is they tell us, they kind of help regulate your temperature. As these hormones keep decreasing, your thermoregulatory center kind of goes haywire. It's like, okay, I don't know what's happening. And it tries to compensate by overacting. So what happens is you suddenly start feeling hot, your thermoregulatory center activates, and it tells your body to react to it, which is it causes vasodilation, which is the blood vessels in our skin kind of dilate. That is a heat dissipation mechanism that works. And you feel, as it dilates, you sweat more. That causes those night sweats and the vasomotor. That's the mechanism, like how people, what is the reason behind those hot flashes? Yeah.
So when you think about that, then we have these hormones impacting the brain. So as you mentioned, they're impacting basically the center that regulates our core body temperature. And so, yes, you can have those symptoms, and people often wake up with those symptoms in the middle of the night. Yeah. I believe that there might be some circadian pattern to that, meaning that there might be certain times when you might be more prone to having hot flashes. I thought I read some literature on that. I wasn't sure if you were aware of that or not.
So I haven't read anything about, or had people complain about hot flashes happening at certain particular times, but I know that they're more troublesome for most women that come. They are more troubled by it when they're sleeping because it wakes them up. And all the other things that happen along with it, like there's anxiety, so they might have trouble falling back to sleep. So that is why I think it is most women complain that yes, they do happen during the day, but the most trouble that they have is when they start appearing at night.
And with the vasodilation and the more sweating, do they also have other physiologic things that may keep them up? Like, do we tend to see a higher heart rate? I've had some women say, well, I wake up, I have palpitations.
Yeah,
I think it would be part of that process.
yeah, definitely. It's, it's like they last for 1 to 5 minutes, and some women do experience a higher heart rate with it. So it's all that body compensating for the changes in the hormone levels that presents as this.
And does estrogen and progesterone, or I don't know if it's both hormones or maybe one, are there some effects on how we make serotonin, which is one of our happy hormones in our brain? Do you think that has anything to do with any of the mood changes we might be seeing?
Yeah, serotonin. So estrogen and progesterone, as they decline, I think that is what affects the serotonin levels too. And that definitely, so progesterone per se, more than estrogen, is also known as, or what I remember as, a calming hormone. So, as women go in menopause, this calming hormone, progesterone, is all of a sudden declining. And in some cases, it is not being produced. And that is what causes all the mood changes and the irritability that you see.
Ooh, okay. And what is funny is I actually read this to add to what you're saying. Mm-hmm. I actually read this, guys. This is real. There's some literature about this. Some folks have actually been able to show that progesterone is so impactful to calming one for sleep, that it may actually be almost as effective as benzodiazepines. My goal is to get them off of these medications if I can. Things like Xanax, that's a very, that is a short-acting benzodiazepine. A longer one would be Klonopin. Ativan is another brand. So I'm just giving you examples of different benzodiazepines that work in sort of different lengths of time or have different metabolic effects. But these are very common for acute episodes of anxiety, for example. Yeah. Klonopin being longer acting sometimes is used for other reasons, but especially for the shorter acting kind of medications, people will often tell me, oh, well, it helps. I take it. I'm able to fall asleep. They're not able to maintain sleep. And there's a lot of reasons for that have to do with that medication. But the fact is that progesterone may be kind of like our body's benzodiazepine, if you will, which is really crazy when you think about it, that we have been supplementing with addictive medications when in reality there may be an alternative. So if we're having all of these hormonal changes during that time, how long does menopause even last? Like, what does it mean? So once you're in it, is it just like, okay, you're in it for the rest of your life? Do symptoms dissipate over time? Like, how long do these perimenopausal symptoms still continue into menopause?
Wouldn't it be wonderful if it lasted like a year and then you're done, right? That would be amazing. But I am sorry, unfortunately, that is not the case. So symptoms can go on in some women up to 10 years and even more.
Wow. Okay, so they can have some form of issues related to that. Mm-hmm.
And it's not just about that. I think the important thing that people need to realize is that it changes everything, right? Till now, your body has been producing these hormones that are keeping your body happy. But now, with the lack of these hormones and these symptoms of menopause, which most common people know is, vasomotor symptoms and the mood changes, everybody talks about that. What we don't talk about, I think, is the long term what happens, the bone health that you think about, if you think about, right?
Right. So what happens? Tell us about some of those long-term consequences of aging, essentially.
Yeah. So I think of it as, estrogen and progesterone are like female testosterone, in the sense that they keep everything in our body working and functional. As these decline, there are so many things happen. Your heart is affected. So estrogen has shown to be protective for a lot of these things, estrogen and progesterone. So your cardiovascular risk factor rises, right? We talked about central adiposity, that is rising.
More fat in the middle, it means that there's more fat that's accumulating around your organs, and that tends to increase your risk for having heart problems later on.
So, your cholesterol rises, your LDL rises, HDL, which is the protective cholesterol, decreases. These are some of the effects that you see that increase your cardiovascular risk. The glucose intolerance is another.
It's a great point.
Yeah, a lot of women can develop fatty liver. That's another thing that happens in terms of long-term effects of not having estrogen and progesterone being secreted. Hypertension, arterial hypertension has been shown to be associated with long-term effects that menopause can have. And then the well-known one, osteoporosis. Yes, right? The bone loss. Estrogen is protective. When you do not have estrogen, there's bone loss, and there's a higher chance of fractures, whether it is the neck of the femur. Hip fractures are very often seen in women. You can start from the top and go to the bottom. Any part of your body you think, that can be implicated. Arthritis is one. And the common, actually, this I would say we haven't talked about it, but the sexual issues that women face at that, right? Because it is something that women don't talk about much. A lot of women, or avoid this topic, but is a lot of sexual dysfunction that happens. So estrogen is a hormone that keeps your vagina moist by increasing the secretions. It helps with the lining of the vagina. It makes it thick. When you lose that estrogen, that lining thins down, and there is vaginal dryness. Women complain about that. There is loss of lubrication because there are no more secretions, so painful sex. So it is called GSM. Genitourinary symptoms that you see would be, painful urination, burns. There are people who say like there's some fire down there. Yeah. Painful sex, painful urination. These are bothersome symptoms that some women don't even bring up. And you actually have to ask them specifically, like, what else do you see? Is sex painful? Do you have pain when you're urinating? And half of them go, yes, but I thought that was just a part of it,
As we age and we lose these hormones, do we also have an increased risk of having to use the restroom more frequently? Does it do something to the pelvic floor at all, or cause any atrophy or weakness, if you will?
It does, yes.
How our bladders function?
Yes, so it does. So those muscles atrophy, as you just said. So that the angle at which, your bladder and the urethra is connected, because of that atrophy, that angle changes, and that leads to, problems holding urine. So there's more chance of having urinary incontinence. There is frequency, there's urgency that you see in these women, and higher chance of prolapse, just because all your pelvic support is not as healthy as it used to be. The lack of these hormones causes that, and you see a lot of women presenting with those symptoms too.
So this is wild, because all of these other downstream effects actually kind of go back to how do we sleep? What are some things that can negatively impact our sleep? Well, if you're looking at your urination issues, getting up to have to pee all the time because now you've established prolapse or what have you.
Yeah.
We've already discussed the hot flashes and what have you. And then just in general, oftentimes because we're not sleeping as well for various reasons, we also have the issues related to, then we start to change our behaviors during the day that will then have downstream effects and make things worse. We don't have as much energy because we're moody and we're tired. So hitting the gym is that much harder. We've also been taught as a society, and we need to emphasize cardiovascular health, get on that elliptical, start running, doing a lot of things that may be not so easy if you're developing arthritis and your joints hurt. And you're not, and you have prolapse, for example. And it's not all about the cardiovascular health. Yes, that's important, but you're bringing up something about the bones, which is you need weight-bearing exercise to try to actually maintain your bone health as we age as well. So continuing the type of exercise we do may need to shift. Yes, we encourage it in youth, but finding ways to continue that are really important as well, because the more you move, the more you exercise, all these things just throughout our lifespan help us sort of sleep better as well.
And now a quick break, but don't go anywhere. We'll be right back.
With sleep, Dr. Cole is here to help. Whether you need a comprehensive sleeping coach program, suspect you have sleep apnea, or simply seek a second opinion, she's available for consultations in New Jersey, New York, California, and Georgia, with more states coming soon. Schedule your free 15-minute consultation today to find out which visit is right for you at AskTheSleepMD.com and start your journey to better sleep with a trusted physician.
If you are liking this podcast, if you're finding it educational, if you are feeling more empowered to go to your doctor with any sleep issues that you might be having to address them, please, please, please lend your support. Make sure that you are liking, following, subscribing. I am available on YouTube. I'm also on Apple, Spotify, or wherever you get your favorite podcasts. The website has launched. So we have AskTheSleepMD.com to be your free educational resource. We've added many new blog posts filled with juicy information. If you would like to support the podcast, we now have a way for you to donate. This is a labor of love. I truly enjoy what I am doing. It would be inspiring and truly helpful if you wouldn't mind even so much as donating $1 to keep this podcast going, particularly if you really find this free education a good platform for you and a good resource for you. I also have affiliate links for products that I'm a proponent of, such as Quiet Mind. So please check out the website, sign up, and you will get the latest news, the latest blogs, some sleep tips, and just have a great day and keep listening. Okay, guys, sleep well.
Always, I'm going to emphasize to you guys that regardless what you put in your body, what you eat, your diet may need to be much stricter. If any of us are on the planet in your 40s, 50s, 60s, trust me, you remember when you were 20 and what you could eat when you were 20. If you even look at it sometimes, at least I perceive, it's like, oh, I looked at that. Okay, I think I just gained a pound from looking at all that salt. You know, it's like one of those things it's our metabolism changes, how many calories we can consume change. There's so many interrelated processes here. So menopause really is a whole systemic issue, as you pointed out.
Yeah.
And then I also wanted to highlight, guys, that a couple of things that are really key here is we're emphasizing some of the things that we can do in terms of, and we're going to move toward sort of management of menopause in a bit. Mm-hmm. But I wanted to highlight that, and I've talked about it a lot on the show specific to obstructive sleep apnea. One of the things we also know about our hormones are that they are relatively protective of our airway. It somehow impacts the tone of our upper airway muscles, and probably the weight gain issues and metabolic changes that occur in menopause also increase our risk for our upper airway closing off. The other thing that I haven't emphasized as much, but I want to emphasize here, is there are folks that will complain of that they'll start to get more either leg cramping or sensation of a creepy crawly sensation in their legs, primarily occurring in the evening when they're trying to relax. It doesn't need to be exactly before bed. And that is something that we often call restless legs syndrome. And that is much more common as we age. It's more common in women in general, I think primarily because we lose blood every month. But we also see it more with hormonal changes. And there may be some downstream effects on dopamine production in our brain that are related to those hormonal changes. So those two common sleep disorders may also sort of add fuel to the already difficult fire that is just sort of smoldering and percolating as we go through time and age. Those are other topics for other discussions, but I think worthy of discussion is one of the reasons why I like doing the show and talking to you and other folks like you, Parul, is I want women to know especially that the more you know, the more you hear these things, the more apt you are, more likely you are to actually talk to your doctor about it. Because a lot of what you're saying, you're emphasizing it. It's not just, well, I just thought like that's just the way it has to be, right? I think have this mindset, well, women get older, they go through all this stuff, and that's just the way it is. And now we're rethinking that. So how do we take our bodies back to the auto shop and put the wheels back on the bus, so to speak? What are the tools that we have aside from those good behaviors, those stress management techniques, mindfulness techniques? Those are actual real. There's some data that supports that if you do certain mindfulness techniques, you can actually help with some of the hot flashes, for example, just by how your mind works. Not everything requires a pill or a medication or supplementation, but for those of us who are like, okay, that's great, stop telling me to do good sleep hygiene and exercise more. What can I do? I'm really suffering. What do we have out there? What do we know?
Yeah, so that brings us to the very important topic of hormone replacement therapy. I think it is well proven now that hormone replacement therapy is one of the best things that I feel like it's one of the best things that's happened to women.
But it used to be considered one of the worst things, right? So we're here to kind of debunk that a bit.
Yeah. So going back, it was actually initially it was considered till like 2002. It was considered that it had like all these cardioprotective effects, and then came the Women's Health Initiative study, which kind of just it set up a good. It set women up to be more cautious about hormone therapy, but then there were a lot of issues with that study. That study said that combined estrogen and progesterone therapy raised the risk of certain things like breast cancer, did not show protection against cardiovascular symptoms or risk factors, but there were certain flaws with that study. So what is recommended now is that there is like the sweet window that I call, which is within 10 years of menopause or less than age 60. So women who are less than 60 and are within the 10-year span of menopause are the right candidate for hormone therapy. Yes, there are some situations where you would not want to give hormone therapy, and those are very few. Going back to numbers, we talked about how many women have symptoms and how many women every year are going into menopause. I was just reading again, 2021, there were around 3,400 women who could actually not do hormone replacement therapy. So that's a small number. Yes, it is a significant number, but it's a small number. So most women can actually do hormone replacement therapy. The only ones that I would say are, the conditions that are contraindications would be if they have undiagnosed vaginal bleeding, if they have active breast cancer, if they have a history of thromboembolic, venous thromboembolic.
Blood clots, guys. Blood clots. Big deal.
Yes.
Yeah.
Blood clots. And coronary heart disease. So these would be the only patients who cannot or are not good candidates for hormone replacement therapy. All other women, yes, it's nuanced, right? There are other things you consider. There's age, there is the type of formulation that you would do, there is mode of delivery and what patient preferences are. Yes, all those factors play, but hormone replacement therapy is something that most women can do. And I think the key here, as we were talking, is education. So many women still, based on the study, the WHI study, which people go on and which basically created this wave of, this time when people and women wanted to run away from hormone replacement therapy. So what happened with that actually was, I think that is also important to know, that in that study, the major drawbacks of that study were that the age that we just talked about, that study missed that age criteria. Most of the women that were enrolled in that study were more than 63 years old. So they probably, they had gone through those 10 years of around menopause where this therapy, hormone replacement therapy, is most useful.
So do you tend to stop therapy then around, or in general, to practicing OBs or practicing people who are prescribing this generally, like once you hit 60 is when, or after you hit 60 is when you kind of stop the hormone therapy, or do some people continue it past that? I'm just curious.
No, so there's no definitive guideline. There is no guideline that says you have to stop at 60. It's more of a shared decision. it is based on, even when women are on hormone therapy, they should follow up with their healthcare provider regularly to see whether and evaluate whether they need continual hormonal therapy or not. So it depends on whether they have these symptoms, the hot flashes. So again, hormone therapy, hot flashes, right? Vasomotor symptoms, that is what it is FDA approved for. That is the most common reason it is given. And for preventing the risk of osteoporosis. So these are two major indications that one would prescribe hormone replacement therapy for. It's very fluid. You have to evaluate how the patient is feeling, what her symptoms are, what her desires are, to decide whether or not to stop hormone therapy. So in short, there's no definitive age. Yes, if there is a patient who comes up to me and is more than 65 and asks for hormone therapy, that would be a time when we would have this discussion, that there are these risks that have been shown in older women about when they take hormone replacement therapy. And even then, it's shared decision making. You decide together what the risk benefit ratio is.
Yes, you've emphasized how hormone replacement therapy could really be very helpful for women. Mm-hmm. But I think perhaps the most powerful thing that you were mentioning here is something that we talk so much about in healthcare in general, and it doesn't just stop at menopause, it's with everything, which is the concept of, in the medical parlance, shared decision making. Yeah. And for those of you who are the patient, and guess what? We're providers and we're patients too. So this counts for us, counts for everyone. The bottom line is having this dialogue with your provider and finding that provider who's willing to spend the time to have that dialogue. By the way, guys, right? We're out there. We exist. We want to talk to you and we want to have a conversation with you and make sure we all feel comfortable with what the plan of action is. But you are an active participant. This is not doctor tells you to do blank and you do blank and there's no questioning. And there's some people for which they want to relinquish a bit of that shared decision making. But for the majority of us, at least this is my view, I really think knowing as much as you can and asking those questions, and believe me, your provider comes in, they want to know what's on your mind. So get to it. Don't be afraid. Like when they're got their hand on the door and they're like stressed out about having to go see their 15 other people, that's not the time to start bringing this up. Like this is not like, we'll have to deal with this and this, so it's not so important. It is important. So let's pay attention to it, because if you pay attention to those symptoms, it has downstream effects for the rest of your health. And I think that's really, really key, that it's not the fourth thing on your list. It should be one or two.
Yeah, you're right. It begins with education, right? First, you have to know that, okay, these symptoms, these odd things that are happening with me are actually a symptom of menopause. That's where education comes in. And then once you know that, you have to be able to and feel, safe enough to bring this topic amongst your family members, whether it's, a family member, a healthcare provider. Go seek that help, because you don't know unless you ask. Exactly. A lot of women suffer. Like, why? If you think of it, the age expectancy in 2024 for women is 73 years. It's going to increase, believe me. By 2030, I think it's going to be somewhere around 79. And we just talked, average age of menopause is 45.
So you're spending literally like a third of your life in this transition. So the last third of your life should not suck, in my mind. I think we need to figure out ways to make it less sucky at the end of the day. I also wanted to ask you, because I know you have done a lot of research in this area. Mm-hmm. You mentioned there are people who are not candidates. Yeah. What the heck can they do about their menopausal symptoms? Are they just left in the dust and they're the ones that have to deal with it? Or are there some other alternatives out there that might be worth discussing with your provider?
That is such a great question, because research, right? You have to love research. There are new drugs that are coming up that women who cannot take hormone replacement therapy or who do not want to take hormone replacement therapy can start to help with specifically, vasomotor symptoms. So again, here, the first thing I would want to stress is the gold standard, like the first drug that anybody would want to prescribe would be hormone replacement. These set of drugs is more important for people who have real contraindications. So there's a new class of drugs that is called, for geeks, neurokinin B receptor inhibitors. There's one drug that was recently approved. It's a complicated name. It's fezolinetant. That is the drug that has been approved last year for vasomotor symptoms. These are interesting times, as I said. This drug, it acts on the thermoregulatory center of our brain that we were talking about. There are some receptors in our brain that estrogen, when it is being produced in the body, it binds to those receptors and tells those receptors to not function as much, which in turn decreases all the heat dissipation, helps us regulate our body temperature. As the estrogen goes down, these receptors become overstimulated, which leads to hot flashes. So that is the novel or the new mechanism that these drugs work on. It is an oral medication. What's interesting about this drug is that obviously it's a non-hormonal, so it doesn't affect the estrogen levels, your progesterone levels. And that is kind of what I would tell people to realize, is because it doesn't contain the estrogen and progesterone, this drug doesn't have it. One of the things that you would see is that its only effect is on vasomotor symptoms. So it doesn't offer the protection that HRT offers in terms of osteoporosis, your cardiovascular risks. You have to take everything with a grain of salt. This is a relatively new drug, so it's not like the safety data is not yet that robust. Before I start prescribing this drug, or anybody, I hope, you would like to see more data on the safety. The trials that led to the approval of this drug, they were called the Skylight trials. They did Skylight 1 and Skylight 2. The interesting part was that, yes, it did show that, fezolinetant significantly reduced vasomotor symptoms. But what I find interesting is, if you look, most of the women who were enrolled in this study were in the age group 40 to 65. Yes, right age, right? Most of them had around 8 or more hot flashes a day. The interesting part is they also had a control group where, the patients who were enrolled, they got a placebo. The other group is getting fezolinetant, and they tested 2 doses, 30 milligram, and I think the other one's 45 milligram. So the interesting part that I find is, even with patients who took placebo, they had a decrease in their vasomotor symptoms. So when compared, a little bit of
a placebo effect,
right? That is the placebo effect, right? So what is interesting is fezolinetant only decreased hot flashes by 2 per day as compared to placebo. Yeah, so that is what I find interesting. Like, this is still a new drug, as I said, and yes, it could be beneficial. Yes, true. When somebody has like 5 or 6 hot flashes and they go down so placebo decreased them by 3 less hot flashes a day. Fezolinetant takes away 5. Great. But what about the women who have more hot flashes,
Did they do any quality of life type of stuff? Because at the end of the day, we can say, okay, well, your number decreased by blank, so therefore we would expect blank. But sometimes just a little bit of decrease has a big effect on how people feel. It makes people, at the end of the day, what do I care about? It's like, how does the patient feel? What's the quality of life there?
Yeah, that's what I was coming to. So it did show that it improved quality of life, especially concerning sleep. And what was interesting is that these are self-reported scores. So most of the studies that you would see with menopause, hormone replacement therapy, or a non-hormonal drug, and sleep, and you can probably speak more to that, Allison, but most of the studies, I as far as I've read, they've shown that these are self-reported scores that improve. So the subjective improves. It's not the objective. I think it's really hard to show.
That's very interesting, right? So guys, you're hitting the nail on the head, is that these medications, hormones, drugs, They are helping you feel better at the end of the day. Yeah, they really are. Parul, this has been such a fun discussion. I know, fantastic. I know I had a big ask of you to talk about a topic where I'm very interested in this, but as you can tell, there's a lot I know about sleep disorders per se, but the world of women and perimenopause, this is stuff that I'm learning too. So you're helping me learn, you're helping the world learn, and it's really, really cool to have gotten to meet you in my orbit. Thank you so much for your time. This is really fun. I know we'll be having future conversations offline.
Yeah,
for
for sure. Thank you, Allison, for having me. It is a pleasure. Yes, women and women's health is something that is really close to my heart. And believe me, as you say, I learn every day. I read about menopause and I'm like, oh my goodness, this is what's gonna be my future,
Exactly.
So yeah, that is definitely, something I like educating people.
Again, you now know that there are both hormone replacement alternatives, non-hormone replacement alternatives, and that all adds up to all the other good stuff that we need to start in our youth if we possibly can and carry through as we get older, as difficult as that is. So I hope that you found this helpful. Please like, rate, subscribe, share, all that good stuff that we tell you to do on social media. Thank you again for listening. Disclaimer. The statements made on this podcast have not been evaluated by the U.S. Food or Drug Administration. They are not intended to diagnose, treat, cure, or prevent disease. The information provided by this podcast should not be used as individual medical advice. While I am a practicing sleep provider, I am not your sleep provider. You should always consult with your personal healthcare provider for individual recommendations and treatment.